this is Roger Green, host of the Surfing the NASH Tsunami podcast. This week, we are offering 4 conversations from episode 48, closing thoughts on an eventful NASH summer. In this conversation, I asked the panelists to allocate 100 points of importance between the 3 major topics discussed on the podcast. The allocations vary, and the reasoning behind them varies even more. This brief conversation will leave you with a great deal to ponder. So sit back, listen, enjoy, learn, and when you're done, join the discussion on our LinkedIn and Facebook discussion groups.
Roger Green.
I'm going to do something marketing researchers do, right? You have 100 points of importance to place on the 3 of those. Improvement in MR measurement tools and MRE, better drugs, better methods that may reduce placebo if it works, and also reduce screen fail rates. 100 points. How important do you think each of these will be to us doing a better job of figuring everything out about this disease over the next 5 years? Drugs, MR, on multiple slides. Has to add up to 100. 3 numbers. If they're all equal, it's a third, a third, a third. If only one of them matters, it's 100, 0, 0. How would you assign the 100 points? Asking each of you.
Mazen Noureddin.
Man, where do you get those from? That's a tough question. Louise, go first.
Louise Campbell.
All right, boys, let's really have a look at it. Now, I would actually go with 60 points for Stephen's changing the amount of biopsy tissue that we look at, because I think the more cost effective it is to screen and recruit for a study and not exclude patients on if we could have got more slides, and the disappointment of that for patients, then everybody gets a fair crack. And it's the best evidence. If we've got the best quantity of slides to rule in patients into that study, we're going to have less screen failure. We get the drugs and the evidence that much quicker, because we know that adds so much time. I would probably go, therefore, 30 for efruxifermin and or the medications that are coming, and 10 for MRE, because MRE is a fantastic tool, but it's about getting people to MRE, or getting MRE to people in the right locations. That's currently difficult, so unless that changes, then I can't see. So I'd do 60, 30, 10. I think that's 100 at this time of night.
That is 100, and that's really good guts to go first. Nice job. Which one of you heroes would like to follow her?
Stephen Harrison.
Roger, I'd like to hear yours. You're the one that asked us the question. You tell us your thoughts.
I like that.
The truth of the matter is, it's very good. I ask questions without knowing what I think the answer is. That's what marketing researchers are supposed to do. But I agree with Louise that I probably put the slides first or tied for first, but FGF21 has a chance to match that, because if in fact you produce that result in phase 2B, then the entire profile of investment and excitement around the class amps up dramatically if people think something that good might be coming that quickly. So I might go more like 40-40-20 or maybe 45-45-10. I think the 10 on the MRE is still right, because if you get the other 2 right, the MRE will matter less. So let me do 45-45-10.
I'm going to give Mazen a break. He can go last. If I heard you correct, Roger, you weren't asking specifically about efruxifermin. You were speaking to drugs. You were focusing maybe a little on the FGF21. So I'm going to call your bluff slightly on that. And I'm going to say another military analogy. If you want to hit a target, the best way to hit a target is use an 8-digit grid coordinate. Because that I can give a Marine, I can give a SEAL, I can give anybody an 8-digit grid, and they can get within 10 to 20 feet of a location. So we need our 8-digit grid coordinate for an endpoint. And if we're able to improve that endpoint, then we can drop our munitions onto that endpoint more precisely and more accurately. So to that end, whatever I can do to improve my endpoint assessment, as minimal as it may be, that becomes most important. So in that vein, I think it is something that improves our accuracy of diagnosing NASH and showing that it's gone and resolved, as long as we're beholden to a biopsy endpoint. And I think a simple thing might be just looking at more tissue through looking at several H&E slides. So I'm going to give that 60 points like Louise did. And then, when we begin to look at NITs versus MRE versus drugs, we don't really care about NITs so much if we don't have drugs to treat the disease. So I need a nuclear warhead, or I need an 800-pound bomb that I can drop on that 10-digit grid and take out the disease. So to me, that's drug development. And then at the end, I'm going to need an NIT, but I don't need an NIT if I don't have a drug to treat the disease, because at that point, it's just prognosticating when the patient's going to need a liver transplant or they're going to die from their disease. So I'm going to go 60 for the H&Es, and then 25 for drug and 15 for NITs, for in the context that we're talking about today. All right, Mazen.
I mean, there's a whole whirlwind with that answer. I'll just do it a little bit differently. So I'm actually going to go against these answers. Like, I've been doing this since yesterday.
Good courage, my friend. Keep going.
Yeah, my wife loves IKEA, and I don't like IKEA, especially if I have to put the bed, and she wanted IKEA bed for our daughter yesterday, and I've been going against that since yesterday, so I'll do the same right now. I will argue that right now, despite all the biopsies, problems, and issues, we're holding, and we're doing trials, and we're completing them, and this is because the disease is so prevalent. Unfortunately, we're sacrificing a lot of patients with screen failures that they are not getting into the studies. So I will say, to me, the most important thing, and to my patients, is to get a drug approved in the next 2-3 years. Nevertheless, I'll give that about 40%. I'll give the histology because of that, because we're doing the trials already, that you gave 60%, 20%. I'm gonna give the NITs the other 40%. The reason why I say, because a lot of people's are getting tired of the biopsy altogether, and they don't want to hear about improving its problems and its efficiencies. They want to do trials more efficiently, in a better way, not talk to the patients about the biopsies. A lot of sites that they started doing NASH trials are out of it because of the biopsy. I'll argue that let's move out of it in the most possible efficient way, get NITs, do trials with NITs, and call it a day and get more drugs approved. So I'll say 40-40 for drugs and moving away with NITs, and 20% for the biopsy. That's my analogy without nuclear pumps.
Well, you did have an IKEA analogy, but...
And by the way, and controversy is always a good thing. I'm mindful of Manal Abdulmalik last week predicating her interview on the idea that says 5 years from now is exciting, but I give a talk about that, and the doctor looks at me and says, okay, what do I do with my cirrhotic patients today? And she goes off in a whole different direction.
Cirrhotics are completely different. Once you talk about the drugs and cirrhotics, I mean, we talked about the acute drug and all this, but cirrhotics is a different beast.
I really appreciate all those answers, and I'm going to ask one more real quick wrap-up question. 1 sentence to 2 sentences, no more. What should listeners take away from this discussion? Brave one, go first.
That my wife shouldn't listen to this episode and hear about the IKEA bed argument.
I love IKEA. I'm with your wife on this one.
It takes me, I'm not a handyman, it takes me 8 hours to put a bed from IKEA. But anyways.
You can take away from this that the U.S. and the U.K. are still aligned, and that the Middle East is diametrically opposed, or you can take away from it that each of them are equally as important. I mean, if you took the mean of what we said, we're probably closer to splitting the difference down the middle across all three. Or you can take away that we all have different things we hold dear and different things that we feel are important. At the end of the day, they're all important. Every one of these issues that we talked about today are critical to drug development, and NASH are critical to getting at finding the patients that have the disease and getting them to appropriate care. So if you listen to today's podcast, think about those 3 aspects of what we talked about and how you can be part of the solution in advancing this field.
Okay, so Mazen, you're going to stand on your IKEA answer, or you got anything to add?
No. It was a good summer. A lot of data are coming out. The trials, I mentioned 2. One came out yesterday. I look forward to the USLD. There are so many NITs and others. There's artificial intelligence. We're presenting some. Others are presenting more. So it's just going to be exciting, and I'm happy for the patients. I'm happy for the field, and it's going to move forward in the next year and 2. And I think you're sure it's going to just be more exciting every week we come on it. So I look forward to be here again and see where the field is going.
Fantastic. Louise?
I'll just echo what the guys have said. We've got resources there. As long as biopsy is still the FDA outcome that we need to therefore maximise the use of the tissue that somebody's given. We've got the technology. We have the amount. Let's use it. Let's screen fail less people. Get these trials recruiting quickly, and then we will get medications approved in a more timely fashion.
I'm somewhere between where Louise was, which is that the fastest way to move this forward is to open the gates to get more patients in, and screen fail is probably the fastest way to do that. And where Stephen was, which is, this is a little bit like a Rashomon or blind people touching the elephant, right? It almost doesn't matter where you touch it. Something can improve. So wherever in the chain you are, if you ask yourself, how can you push it forward about 10% from where you are, and do that with passion and belief, then this summer is as exciting as it was, because progress happened from so many different directions all at once. And while on the one hand, some things might be more helpful than others in the short term, in the long run, it all matters. Whatever you want to hit it hard, hit it with belief, and see what you can make happen.
And now, back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please send an email to questions@surfingnash.com. We will be back next Wednesday, October 6th, hopefully discussing the new clinical care pathways published today in gastroenterology. I hope you'll join us then. And until then, stay safe and see you on the podcast. Bye-bye now.